talk about the effectiveness and some limitations of the current sort of standard therapies for autism spectrum disorders. You know, with familiar terms that will kind of help define today, IBI, ABA, and sort of these other related approaches as well in the science. Okay. All right, so released, I guess, late last year, we had a release from the Canadian Pediatric Society from our very own Jess Bryant, as well as a few other ECHO members. I believe Susan Cosgrove and Melanie Penner also were involved. And the position statement here was really that pediatricians and other primary care providers in the community are well positioned to really help coordinate this psychosocial and medical care, as well as supports and services for our children with autism spectrum disorder. And some of the key mentions they talked about would be helping, you know, physicians help providing sort of the information about essential and effective treatment interventions and programs, as well as helping families sort of facilitate enrollment into those intervention programs. Okay, as well, so in addition to the Canadian Pediatric Society, we also on the next slide have sort of, again, similar theme here, but the American Academy of Pediatrics also sort of talked about earlier this year around, you know, physicians and community care providers helping ensure that children who have ASD are provided with this evidence-based services to address these sort of academic, social, behavioral needs, and that, you know, it is important that we help inform our patients and our families about what best practices are. So we included these slides because it's very relevant to the talk today, as sort of a rationale, and what we hope that you'll sort of get out of today are some of these main points. Okay. So we're going to start with just a definition of applied behavioral analysis. So this is a scientific approach to understanding and influencing behavior. And I think it's important to understand that it's this sort of the science, this broad science, and it refers to these sets of principles that really focus on, you know, how behaviors might change, how behaviors are sort of affected by variables in the environment, and as well as how we learn. And sometimes you'll hear this term used to it, you know, to talk about a type of therapy, but I really want you to think about ABA as sort of this umbrella term that really, you know, focuses on these principles on how we teach versus a specific type, because there are lots and lots of different things that fall under applied behavioral analysis. For both autism as well as other behaviors and developmental disorders as well. So, but we'll move into sort of some examples of ABA-based interventions on the next slide. And the reason why, you know, there's many, like I said, but the reason why I'm sort of mentioning these is these are sort of these different packages or styles of ABA-based interventions that you may have seen or read about. A lot of families, when they start to look into, post-diagnosis, what do I do? Where do I go? A lot of service providers and websites will sort of mention these. There are, again, many more, but I did want to just sort of address these as a start. But one would be DTT, so discrete trial training. We see a lot of that in what you would know as sort of an IBI program. Incidental teaching or net teaching, so teaching in the natural environment, PRT, which is pivotal response training. We also have here early intensive behavioral interventions, which are in Ontario, we're known as IBI, intensive behavioral interventions, but we also in the literature, we have early intensive behavioral interventions. So they sort of are overlapping, and we'll talk a little bit more about them in a bit. Early Start Denver model. So we have that there, and it's italicized because this is sort of, we'll talk a little bit more about it, but this is a naturalistic sort of behavior intervention that's based on ABA principles, but also based on sort of developmental research as well. So it's there because it's one of those ABA packages you might see, but we'll talk a little bit more about NDBI in a little bit. Direct instruction is another term you might hear, or DI, precision teaching, or even verbal behavior. Okay, and the point of this slide is, again, just to understand that these are all, they're all based on that, again, that science, that umbrella science of ABA, but they may take different sets of principles and combine them into these sort of packages or types of interventions. Okay, so now we're going to sort of talk about these two, well, I'm going to talk first about these two sort of core models of ABA. And the two branches of that would be this IBI is what we know in Ontario, which I have there in orange, as well as this EIBI, which is what you'll see in most literature outside of sort of Ontario, but the models are the same. And then the other model that I'm going to talk about is sort of this focused ABA model as well. Okay, so we're going to start here. So this IBI or this EIBI is this comprehensive intensive service model. There is evidence from group designs and large community implementation. And this is a really good fit for a lot of learners who sort of have needs across a lot of multiple developmental domains. So these are kids that might need support with communication, perhaps behavior reduction, some skill building, some adaptive skills. Okay, so their needs are sort of a little more broad. Now in Ontario, you'll see that a lot of our kids have received this IBI, which was previously sort of funded, and they would sort of, it would be a school replacement. So they'd be sort of in IBI programs from a 9 to 4, 9 to 3 kind of day. So again, in the research, we look at that 25-hour to 40-hour per week of these intensive services. And again, that can vary in the literature and also vary depending on funding models as well. But in Ontario, it was that sort of 30-hour a week model. And it would typically take place during the school day. The length here is also a distinction between the two kind of types of ABA that we're talking about today. The length here is long. It's usually 2 to 3. I would say actually, maybe I would even change that to 2 to 4 years duration. I see Jazz nodding. So yeah, so it's a long time. So these are programs that are intensive. It's in the name, and they are sort of involved in this program for a long time under the assumption that they're working on this broad spectrum of skills, okay, that they're building. And when we look at sort of the evidence on that, we do see that, there are skills increased around academics or play, learner readiness, communication, some cognitive functions, as well as there also is some components of decreased behavior, whether that's ASD symptoms or also some challenging behaviors. And the other thing I'll mention quickly before we move on is traditionally in Ontario, but also in the research, you'll also see that a lot of the EIBI is for younger kids. Okay, so it's for typically our younger kids would be the ones accessing those services post-diagnosis. Okay, so the other branch of ABA I want to talk about is something called focused ABA-based interventions. So these are sort of, they generally refer to these interventions that target a relatively sort of small number of behaviors or skills, and you implement this sort of until the goal is achieved. So, and then if it's achieved, then there's a discussion on if you would then continue and introduce a new skill set and build on that. It's a good fit for learners who, don't need that comprehensive, intensive service, but would still benefit from some evidence-based behavioral strategies. So again, when we think about ABA, there's a lot of these evidence-based strategies that fall under that umbrella. And what we would say is with comprehensive models, many more of those strategies are used to sort of teach this cross-section of skills, versus focused, you may have a combination of 1, 2, 3 of these skills that you would combine depending on the individual to work on that specific skill. Another important feature of sort of focus is it usually does involve caregiver training right from the beginning, perhaps because it's, one skill as well, and also that the hours are, as you'll see there, there's less hours, right? So there's less intensity with this. Typically in the research, it's, anywhere from 5 to 25 hours. So there's a big overlap. Of course. And I would say that, if we're looking at those higher numbers of hours per week in a focus program, those are typically, for individuals who maybe perhaps have some behavior concerns or challenges that we're working on. And then they may need a little bit more intensive intervention versus those that are maybe skill building and learning something new. So that might be the difference as well. You'll also see here that the duration of these interventions, like I mentioned earlier, are much shorter. So with the comprehensive, we've got anywhere from that 2 to 3, 4-year mark. And with these focused interventions within the province of Ontario, previously, we had these 3-month to 6-month blocks of treatment. And in the research, it can go anywhere up to 2 years. But again, it might not be working on one skill for 2 years. It might be sort of choosing a skill, working on it, mastering that skill, introducing a new skill. Again, under the assumption that there aren't a lot of things to work on and that you're just focusing on 1 or 2 areas. Again, just like comprehensive, the best scenario here would be that they take place across environments. So it could be in the community, it could be in home, center-based, as well as school settings. And there is evidence here, mostly from, there's evidence across multiple studies and mostly from single subject design, which is just the nature of applied behavioral analysis sort of research. And there also is some multiple baseline design as well. Okay, so something else that we wanted to address today is that regardless of the model employed, so regardless of whether this, the individuals in this EIBI, IBI intensive model, or whether they're in a focused ABA model with less hours and, one goal or many, right? The key here is that all of these services should sort of include these following features. So we really wanted to talk about this in terms of these high quality indicators for ABA programs. So the first one we're going to talk about is ongoing comprehensive assessment. So without a doubt, before enrolling in any program, again, regardless of intensity, a pre-assessment is really important to understand sort of strengths and areas of need, and kind of assessing where to begin and ensuring that the goals are meaningful for the individual and the family. As well as individualization. That is so key. So even with those packaged types of programs that are out there, there's still, with ABA, there still needs to be that individualization, right? So what works for one does not work for all. And that is really, really important. So programs should be written for the individual person, regardless, they shouldn't just be printed off. They should be, made specific for them based on sort of that initial pre-assessment. The other thing I'll mention, which I skipped over, is that the ongoing piece. So there's the pre-assessment, which is really, really key in ABA. The other piece that's really important is ongoing sort of data monitoring as well. So that's what that ongoing is. Within the Ontario program, at every 6 months, at a 6-month period, there actually needs to be another assessment done in order to indicate strengths and what has been sort of gained during that treatment time. So it's also a little bit of accountability as well for everyone involved to make sure that, the child is learning throughout the program. Another indicator that that is very, very important, I would say essential, would be this parent caregiver coaching or training. And we have coaching there because I think we want to differentiate between this idea of just didactic delivery of ABA to families. There is some benefit to that, absolutely. But where we look for high quality indicators is actually coaching parents, who are the most important mediators for their children, coaching them to use these strategies. Anyone can use ABA strategies. And this is a real important piece, so that when the child's out of therapy, they're still able to sort of be able to benefit from some of the strategies across environments. Another key component here would be goals are broken down into small teaching steps. Now, this is a fundamental aspect of ABA, and that's where that assessment's really key. So if we know where a learner's at, then with ABA, you're going to see skills broken down into tiny little steps. It can seem really redundant, but it's really important because the whole aspect is sort of rewarding these steps towards completion or successful attainment of a goal. And this is an essential component of that. So as an example, if we were teaching someone, they're going to learn, if the goal was, we're going to learn how to play Candyland, that wouldn't be the goal. In ABA, it would start with, learning how to roll a dice, right? Or learning how to count. or learning how to follow, the board and the order it goes in, being able to match, colors. When you roll a red, can you move to red, right? So all of those goals are taught, and we're making sure the child has those. Interdisciplinary collaboration seems obvious, but so important. A lot of behavior analysts do a lot of interdisciplinary work, specifically with occupational therapists and speech and language pathologists. So that is something that is very important, especially for individuals that may have speech delays or motor delays. That's sort of not an area of expertise of ABA or behavior analysts. So it's really important that that collaboration take place. Data collection. In ABA, you're going to see a lot of data collection. It's super important. If you don't see data collection, it's not an ABA program. I would argue that. So data collection is really, really key. And again, this is to help inform, right, these decisions, and to inform if these strategies from that big umbrella of ABA, that the strategies are effective. And if not, then there would need to sort of be a change in treatment. Generalization, another big piece of this. So what we mean by that in ABA is that, we want the child to learn a skill, or the individual to learn that skill. And so for some kids or some individuals, it may require a structured environment to do that to start. But the generalization piece is so key. So if we can learn it in a one-to-one setting, can we then also maintain that in a group setting or small group setting? Can we also, take that skill we learned, and can we go home and do it at home with mom, with dad, with brother, with grandma? It's really important that we're making sure that, because IBI, I think, in ABA, some of these center-based programs, we want to make sure that the kids can take those skills that are meaningful and apply them in other environments. Otherwise, sort of, what's the point, right? So generalization is key. And also that kind of ties in with that parent coaching as well. Structured and naturalistic settings. So same, we kind of touched on that. We want to make sure that, for some kids, they do need to learn in that structured environment to start. It really depends, again, on that assessment, right? And what the needs are of the family and what works for the child. But we do want to move towards naturalistic settings as much as possible. Function-based intervention plans. So this is another key element of a really high quality ABA program, particularly if you're working with an ABA provider and your goal is to sort of reduce problematic behavior or challenging behavior, then function-based intervention is really, really key. And what we mean by that is, in addition to doing a skill-based assessment, which is that comprehensive assessment I talked about at the beginning, function-based intervention plans would really be asking sort of, why is this behavior happening, right? So it's sort of putting on our investigative hat a little and, probing different scenarios to determine why it's happening. And once we know that and we've confirmed that as sort of a causation, then we can better inform which of those strategies from our, ABA umbrella that we can pull from. And I think that's really important because oftentimes, perhaps in other fields, you're looking at the diagnosis and that's informing some treatment. And in ABA, it's very different. When we, a behavior is just we don't use our research or our literature base to like Google, spitting, in our research bank. Instead, first we would do a function-based assessment and intervention around why is spitting happening? And if the function is, attention seeking or whatever, or sensory, then we use that to go Google into our data and research base. So we're not worried so much about the topography of the behavior as much as sort of the why it's happening, okay? And then lastly, ongoing clinical supervision is another key component of ABA. And here in Ontario, they've done a really good job actually of maintaining this and making sure this is something that is part of at least the funded models. In Ontario right now, I would say that for the most part, the clinical supervision would happen with either a behavior analyst or a psychologist that has expertise in sort of ABA and autism. And regulation is sort of an ongoing sore point for us. We're not there yet. So that is, it's not necessary yet, but it is in the works from the ministry to kind of have that regulated. But a really good high quality program would have these. And I, just checked, I think, last night, and I think there's, 600 BCBAs now or something. you know, so there's a lot more of us here, and you know, hopefully you'll be able to access those whenever you're looking at sort of those programs. Whereas before, I think it was very hard to find some adequate clinical supervision, but hopefully that's not the case anymore. Okay, and then the last slide is just sort of a summary of what we've talked about in this overview of evidence. So we know that interventions based on these behavioral principles of ABA are recognized, you know, currently as the most effective approaches for preschoolers with autism spectrum disorders. And we see improvements in, you know, cognition and language and adaptive functioning with ASD, but you'll see they're bolded, and Jess will get to that soon. We see improvements, but not in all. I think in half, I believe from the research, there was half that showed some quite, you know, robust improvements, but that's not good enough. That's great, but that's, you know, that's not good enough. And I think we'll touch on that. But there is a substantial body of research evidence sort of in RCT, in some meta-analysis, you know, for the last couple decades. And, you know, they conclude essentially, at least in 2012 recently with the meta-analysis here, is the effectiveness of EIBI, or IBI in Ontario, meets the threshold and the criteria for the highest levels of evidence-based treatments with the greatest amount of empirical support. And that will lead nicely into Jess's piece.
So I feel like we're playing good cop, bad cop here. So there is lots of good support for ABA-based intervention, but there still is a lot that we don't really know. So what we still need to understand is what are the treatment components that matter most. So sometimes we think about active ingredients, and there's lots of interest in examining that, but very little evidence still around kind of what components matter. What aspects of intensity or duration or the structure of how a program is run, the location, whether it's center-based or home-based. We do know that parent involvement makes a big difference in ABA programs, and so there are several guidelines that now recommend parent involvement on some level in ABA-based programs, but that really varies. So as Erica said, it can vary from sort of including a bit of a didactic component for parents to understand some of the basics of ABA strategies, all the way up to parent coaching, where parents provide some of the intervention, perhaps in sessions that take place at home. Sometimes even parents come into the centers. And then there are some models that I'll talk about in a few minutes that are exclusively parent delivered. So there's a huge range of parent involvement. But it certainly is identified as one of the key components to successful programs. And aside from that, we really don't know kind of what characteristics matter most and which differences matter. So all of these programs differ on various elements, and we don't really know which ones make a big difference. The other sort of area that we still are researching and don't know enough about is sort of what are the child and family characteristics that predict the best outcomes. So we do have a little bit of evidence that age matters. So some research does show that children who start before age 4 versus after age 4, those who start before age 4 do have better outcomes. There's a recent paper that actually contradicted that I need to read more carefully. We do know that IQ, sort of starting IQ, can be a predictor of successful outcomes. So children who start with higher IQs may have more optimal outcomes, not surprisingly. And then conversely, severity of ASD symptoms can also be sort of have that inverse relationship, adaptive level. One of the things that a lot of researchers are becoming more and more interested in as we go younger in terms of providing intervention is this idea of social motivation. And I actually love this because for me, clinically, it's really the thing that gives me a feeling that a child has a more optimal prognosis. So when I see a child who has that social motivation just intrinsically, I do find that those children are easier to work with. They tend to respond more to the interventions that they've been exposed to. And I think, I mean, it's logical. If you think about it, sort of, it's very hard to teach social motivation. right? So if you have it, you can teach sort of all the component skills that a child might be missing in terms of social competence. But if you don't have social motivation and a child isn't interested in engaging with the world or with the social world, you sort of have to start by building that motivation. And in some of the toddler-based programs, that is sometimes where the starting point is. But certainly from a clinical perspective, when I'm diagnosing a child who comes with their own social motivation, I do see that as a really good prognostic factor. And then there are all sorts of things that researchers are trying to understand, very complex sort of interrelationships, again, which won't surprise anyone, between families' resources, their constraints, how much other stuff they're juggling, what their other priorities are. And family readiness is becoming a really important consideration in the research too, particularly for interventions that rely on parents as primary mediators. But readiness, as you guys, many of you know, readiness to receive a diagnosis plays a really important role in how and when we communicate a diagnosis. And it probably plays an equally important role in sort of family engagement in research, in intervention. There's my other half of my brain. And one of the questions that's out there as we struggle with a system that, although there are lots of resources, doesn't seem to have enough resources to sort of serve all the kids, is are there ways to sort of maximize efficiency of interventions so that we really match the most appropriate interventions to the right kids at the right times? So really the big question for me is which treatment components are the best fit for which children, for how long, and at which developmental stages? So that's a really simple question. So honestly, it's just such a sort of complex interplay of all of these factors, but ultimately that's what we need to find out. And as we get better and better at diagnosing kids younger, one of the big questions that the field has really been tackling over the past decade is, what are the adaptations that are needed for infants and toddlers? Sorry, Selena, if you press forward, it will highlight that point. So we know that ABA-based instructional methods have the most evidence behind them, and particularly for kids who are sort of 4 and up. So now we really need to understand how do we take what we know about those interventions and make them applicable to babies and toddlers. Okay, next slide, please. So this is just sort of my sarcastic slide. Everybody knows that in the early Renaissance, babies were not seen as babies, they were just seen as mini adults. And I do like to remind people that toddlers are not just mini preschoolers, they're very unique little creatures unto themselves, as everyone here knows. So Selena, if you just press forward, you'll see a nice drooly toddler to remind us how different toddlers look from grown-up kids, like preschoolers. So what the research is really showing us, that sort of most of this research has come from this type of research design, longitudinal research design, where we follow babies very early in life, starting say at 2 or 6 months of age, up until they sort of become 3 or 4-year-olds, at which point a diagnosis may be confirmed. And we really look very carefully at what's going on in those early developmental stages. Most of this research takes place in the context of sort of a set of kids who are referred to as high-risk kids or high-risk families because they have genetic predisposition to have autism by virtue of having an older sibling with autism. So what this sort of body of research that is really highlighting is that there's sort of some key developmental domains that are particularly relevant for ASD in those early stages of life. So one is attention, so controlling and moving and regulating your attention. The other is emotion regulation, managing and controlling your emotions. Relationship building, not surprising, it's important for everyone very early in life, sharing affect, and really learning to value and how to value social interaction and the social world. And a lot of that comes out of developing social routines and understanding social routines in play. And then of course, communication is a really key developmental target for kids in this age group. So with all of that in mind, trying to sort of use what we know about behavioral intervention to develop toddler-based programs. Sorry, Selena. So this is just a little summary. I'm not going to spend too much time on it, but there was a really interesting paper that came out 5 years ago now by Laura Schreibman and several kind of leaders in the field, where they sort of coined a new term, which was naturalistic developmental behavioral interventions, NDBIs. You'll see it more and more. It's kind of, again, another umbrella term that tries to encompass those interventions that are based on behavioral principles, but take into consideration developmental needs with a particular focus on that those very early stages of life. So you can have a copy of these slides. I don't want to spend too much time on it, but basically what these NDBI models have tried to do is to kind of take the best of what we know about behavioral approaches, developmental approaches, and naturalistic interventions, combine them, and create these NDBI programs that are thought to be perhaps sort of the optimal combination of those strategies, and particularly relevant in the toddler years. Sorry, so next slide. So just a little bit of an overview about sort of what are NDBIs, and it really is an umbrella term that captures sort of different types of programs. So some are direct or therapist delivered NDBI programs. Some are parent delivered, and there are iterations in between those. Some are comprehensive, meaning that they may last for a couple of years. They may address more domains or skill targets. They tend to be more intensive in terms of hours per week. And then there are targeted programs, which may really highlight one or two key domains of learning and tend to be briefer duration. And there's sort of every iteration in between these four extremes. So just to highlight sort of one of the best known therapist delivered NDBI programs is the Early Start Denver model. In 2010, so 10 years ago now, they published sort of what really was felt to be a seminal paper that showed that with this type of intervention, 20 hours a week for 2 years, kids really made toddlers made really nice gains in several core domains of IQ, adaptive behavior, and ASD symptoms relative to controls. So there's lots of excitement about the promise of intervening with very young children using ABA-based programs that have a developmental kind of stance to them. Very recently, there was a partial replication of this first finding, so it was a little bit disappointing. It wasn't really a full replication. I won't go into all the details, but essentially they had a 3-site study. 2 of the sites reported significant gains on kind of a collapsed combined language measure, but many of those other gains reported earlier were not, didn't bear out in this replication. And then in 2012, they had also, the developers of ESDM created a parent-delivered version of ESDM called PESDM. And unfortunately, there was no significant treatment effect in that study. So again, based on a very promising early study, there was hope that using the parent-mediated approach to this model would be successful, but there weren't any treatment effects. So we do know that we have some evidence that these therapist-delivered NDBI approaches, when they're intensive, can yield significant developmental gains. There's a little bit of mixed findings out there. And in some jurisdictions, they still end up being quite expensive. So we're still talking about 20 hours a week for 2 years of intervention. So are there other NDBI options out there? And the answer is yes. So there really has been a groundswell in the past 10 years of these parent-delivered models. So there are a couple of premises upon which these are based. One being that parent-mediated models may be a really ideal fit very early in life because babies spend most of the time with their parents. So rather than taking kids out of the home and putting them in a center-based program when they're really, really tiny, maybe we can teach parents some of these core strategies that can then be integrated kind of naturally into the child's life and interactions with their caregivers, potentially increasing the dose if parents are using these strategies all the time, at sort of less cost to the system. And so they're actually, I think this field learned from some of the criticism of the early ABA field and recognized the importance of randomized controlled trials in establishing some of this evidence. So there have been, I think, 14 RCTs now of parent-mediated NDBI interventions for toddlers. And this is just some of them, but basically they're showing significant gains or treatment effects in various areas of communication, engagement, social attention, play skills, social skills, parent effects like parents feeling empowered, learning skills, and sharing positive affect between caregiver and child. So based on some of this research, the Ontario government in 2015, I can't believe it's 5 years ago now, selected 4 sort of evidence-based parent-mediated NDBI programs to implement in communities. Programs were attached to different community providers, and a 3-year demonstration project happened. It is now complete. So if anybody wants to know what happened, what the answers are, you have to go and bug your government to get information about this. But I do think, I think the bottom line is that there are areas and service providers and regions around Ontario that have capacity now to deliver these parent-mediated early interventions. The programs differ. They probably have more commonalities than they have differences. The intention was never to compare one program against the other, but to look at kind of implementation factors, uptake, feasibility, cost, those kinds of things. And so I do think that the ministry has this information, and we know that there are now providers who have these skills that we can make use of in terms of capacity being out there. So Erica, can I turn it back to you to talk through the cases?
Absolutely. Okay, so to help sort of make sense of sort of these 3 sort of models, I guess, of intervention that Jess and I kind of chatted about, we kind of created these scenarios, maybe to help bridge that understanding. So we'll go through the first one in order, because why not? Child A. So child A is 18 months old with a diagnosis of ASD. A little bit about that child is they have some delayed social communication skills and these emerging play skills. And considerations when deciding on sort of what intervention to choose here was that dad was actually at home with the child during the day, and the parent was very willing and keen to be involved. So recommendations, hypothetical recommendations here would be a parent-mediated NDBI program would be a good fit for all the reasons sort of Jess explained earlier, around that the child's already at home given their age as opposed to sending them somewhere. And we have a very willing parent and caregiver who wants to participate and be involved. And in addition to that, a community play group, so a drop-in as well, which would, I think, be a nice opportunity to sort of have those play skills developed, and also an opportunity for that social communication piece as well, right? That generalization piece. Another example here, and obviously we created these and they kind of fit perfectly into these these 3 models. It might not be that simple in real life, but another pathway is, this is a 4.5-year-old child, so they are school age with a diagnosis of autism. Again, so this is a child who has, a limited range of needs. Needs sort of in areas of play skills, some group routines, as well as toileting skills. And again, a consideration here that's important is that because the child's already enrolled in school and the parents want the child to continue, and the child also wants to continue in school. So that's also a nice indication that school is a place of enjoyment, and it's an opportunity for that child to learn a lot of the skills in their areas of need actually as well, right? So the recommendation here could be something like more of a focused ABA model. We're thinking 10-ish hours a week. And the reason for that dosage too is that this is a child in school all day and they're 4.5, right? So it's thinking about how can we fit, time for them to sort of work on these areas of need that doesn't interfere with the school day, or at least doesn't fully interfere with the school day, or even just family time as well, right? So it's utilizing those weekends and other times sort of sprinkled throughout the week to kind of have that intervention. And the other piece that is key here is the parent training as well. Particularly because of the low dose too. The goal would be that, in a toileting program, it would be the parent, right, that would obviously be toileting. And same with these, play skills. We would, the parent would be playing with their child, and we'd hope that we would provide the parent with some strategies to improve play skills at home as well. And then school collaboration is going to be really important here, especially for this learner. When we look at sort of this need of both play, toileting, and group routines, actually, they all kind of fit as well into the school day. So that collaboration with educators and ECEs in the classroom and EAs is going to be really, really key. And then also, obviously, a group play community group would be really nice. So we're thinking sort of a social skills group, behaviorally based, for this learner to just learn in a little more of a structured setting, some important skills to work on following routines, but also these play needs and play routines. And then the last child, so you can guess, what program they're going to fit into here. But basically, this is a 6.5-year-old child with an ADHD and an ASD diagnosis. A brief profile is they have several skill deficits across multiple domains. So we've got adaptive skills, communication, behavior. We also have high rates of property destruction across environments. And this is also a little person with some self-injurious behavior, which is concerning. The other consideration is this is a family that has another sibling at home, and they're worried about sort of the safety, right? With the property destruction and things flying around the house, and also the safety of the individual with the self-injurious behavior. So for this little person, a general recommendation might mean that they might require more of a comprehensive model. Again, because the needs are sort of sprinkled across a lot of domains, and particularly the behavior needs. So it might, it might involve more time and more expertise to work on sort of behavior reduction and replacing some of this property destruction and self-injurious behavior as well. And again, it might need to, especially because of the safety concerns, take place in a clinical setting where safety is easier to mitigate in that sort of environment, and then move towards, again, this small group or this in-home ABA to sort of loosen it up, right? And that's that generalization piece that we spoke about. And then, of course, parent training. With any good program, we would definitely include parent training, whether that happens initially or whether that happens sort of once sort of some skill building has happened, and then it's time to share that and with the parents is sort of up for negotiation depending on the individual nature. But we wanted to just capture these different pathways. We were thinking, like when we were chatting yesterday, like, there should be a flow chart, and it's never that simple, but I think these are some important sort of broad considerations to think about when we're looking at sort of, what would be the best model for these kids. But you can see across all three, there is still some common elements, right? There's that generalization, there's the parent involvement, there's individualization of goals, and also working sort of with community providers or in community settings as well. Okay. And we also, I guess I can speak to this too. So we also, we know that as physicians in the community, you probably get a lot of questions about, where to direct parents. We wanted to leave you with a few resources here as well. Of course, the Autism Ontario program would be a key place to direct parents to, particularly for the funding piece, to make sure that they get in line for that, as well as Autism Ontario. They have a service navigation that is available, and there is a number to call from their website for access to that. And every region has a service navigator. And as well as the Untaba caregiver, there's a brief report as well as a much more dense report, which is linked here as a PDF, which is another good resource if, if parents want to sort of dig in a little bit more to the individualized sort of evidence base for some of those behavioral interventions across age. So what's nice about that is it goes up to 22, and we didn't talk a lot about those youths or young adults. And there is some research out there. There isn't as much, unfortunately, not yet, but there is some evidence that these strategies are also effective for that age cohort, although there's way less robust research for that area. But it does go up to 22, so it's nice too to look at what strategies are evidence-based sort of across that age cohort. Okay, and then I think we've got some time for hopefully a nice